Hi, I'm Javier Jimenez, and I want to talk about tumor regression and allograft rejection after administration of anti-PD-1. Definition: anti-PD-1 is a humanized immunoglobulin monoclonal antibody direct against the negative immunoregulatory human cell surface receptor program DET1 with potential human checkpoint inhibitory and antineoplastic activities. Application in medicine. The New England Journal in Medicine report a case in which PD-1 antibody was administered to a solid organ transplant recipient with metastatic cutaneous squamous cell carcinoma. The patient had a robust anti-tumor response along with allograft rejection. This case suggests that anti-PD-1 can be highly effective against cancer arising in the context of chronic immunosuppression. It also suggests that the PD-1 pathway may be critical in maintaining the partial tolerance that prevents T cells mediated allograft rejection.
Yeah, so we basically did a study at Memorial of all of our patients who were treated with PD-1 inhibitors for melanoma only, and looked at what happened after they discontinued, which is a growing question in our field. And essentially what we saw is that many of the responses really are durable in line with the clinical trial data that we've seen. But over a period of years, we've seen increasing relapses, raising this question about how long we really do need to treat after, particularly after complete response. That's an open question still, and certainly not one that we answered, but our estimated 3-year relapse rate after CR was actually 27%, which is much higher than I think many of us, and myself included, expected. So then we went on to look at what happens when we give patients who did relapse a second course of PD-1, and we were quite surprised to see that the response rate was somewhat lower than expected, 14%. But very interestingly, the response was actually independent of their first response. So we had patients who had a complete response the first time, 8 of them, and only 1 even responded to a second course of treatment. In contrast, we had 8 patients who had progressive disease to their initial course, were retreated with PD-1 for whatever reason. Actually, 2 of those patients responded to a second course. It's very interesting, suggesting, things are changing in the tumor with whatever interval treatments they are having. Clones are evolving, resistance patterns certainly change. So very interesting and compelling, but lots of work to do to follow up on that. We're starting to look at that. So we looked at patients who had either systemic therapy between the two courses or radiation therapy, which we know may change the tumor microenvironment. But some patients didn't and still had a different response the second time. So, I'm a translational scientist. Our next step is to take that back to the lab to really try to analyze those tumors genetically and from a microenvironment perspective.
Pros and cons. Pros, the use of PD-1 or PD-L1 inhibitors in vivo can enhance the immune response of T cells against tumors, inhibit tumors proliferation, and prolong the survival of patients. Cons. Immunotherapy not only costs a lot, but also may delay the disease if the treatment fails. Uses applied in Ecuador. In Ecuador, immunotherapy, also called biologic therapy, is a type of cancer treatment designed to boost the body's natural defenses to fight the cancer. It uses substances either made by the body or in a laboratory to improve or restore immune system function.
Number 4. Advances in immunotherapy for cancer treatment.
Using the body's own immune system to fight cancer isn't something new, but its advancement towards a cure for cancer is. The market for immunotherapeutic cancer therapies has seen an unprecedented number of FDA approvals. One of the most notable advancements is joint therapy, the integration of immunotherapy and chemotherapy. In a sample of patients with metastatic, non-squamous, non-small cell lung cancer, joint therapy has been incredibly effective, more than doubling the cancer response rate from its rate with chemotherapy alone. Other innovations on the immunotherapy front involve therapies derived from T cells. New forms of engineered T cells have exhibited enhanced anti-tumor activity targeting antigens on tumor cells, allowing the body's immune defenses to attack the cancers within a patient. The agent with the most promise in 2019 is that of a T cell receptor, TCR, T cell therapy developed for use in liver cancer, the world's third most deadly. With the near daily discovery of new immunotherapeutic targets, it is the hope that effective therapies will soon exist for all tumor profiles.
Conclusion: antibodies against the program that one PD-1 receptors and one of its ligands, PD-L1, have produced tumor regression in multiple cancer types. This case shows the critical role of the PD-1 pathway both in immune resistance by cancer arising in the context of long-term immunosuppression and in the maintenance of partial adaptive tolerance to transplant organs.
PD-1 and PD-L1 blocking drugs work, they're most active actually at the tumor site. And this makes them very different from anti-CTLA-4 ipilimumab, which has a global impact on the immune response. So when we're looking for markers to help us select patients who might be more likely to respond, or even if we're looking for other molecules that we should be co-targeting in combination regimens, for the PD-1 drugs, we look in the tumor itself. And so we look at you know, what factors, what cytokines, chemokines, what cell types we find in those tumors, and we correlate them with the clinical outcomes. So we published early evidence showing that there was a relationship between tumor expression of PD-L1 with response to anti-PD-1. So PD-L1 is the binding partner for PD-1 that's expressed on activated T cells. This marker, PD-L1, did not seem to predict responses when anti-PD-1 was combined with ipilimumab, but we might not really expect it to, because again, ipilimumab has a global impact on the immune system, and so markers such as PD-L1 may not be relevant to ipilimumab. But this hopefully gives you an idea of the complexity of you know, our challenge now to find these markers that will help us refine these treatments.
Thank you very much.